conference has started or the school has started, we have been worrying about the fact of that, yes, coercion is problematic. Force is not the right way to go. But there is this constant worrying which comes from several people who'd say, yes, we agree that coercion is not the way to go, but then what are the alternatives? We've had thrown at different points of time that when people lack insight, when they can't decide for themselves, when they don't know what they want, then what do we do other than go the force way? This morning's panel is going to be sort of telling you in both theoretical and practical terms that when you say no force, there are real practical alternatives available. There are values and there are principles which inform as to why we can't go the force way. I begin this morning's proceedings by inviting Nell to do the first presentation. You're familiar with all the panelists on here, and those of you I would just say that Nell is teaching at present at Nottingham University, but more importantly, she's been engaging with this whole issue of people with psychosocial and intellectual disabilities, and the fact that why do you absolutely need to speak in terms of alternatives to force? Nell, 15 minutes? You're sure. We'll be going continuously by each of the presenters using 15 minutes. We plan to finish by 10:30. The last half an hour we want to use to have a good, robust discussion with all of you.
Okay. Can everyone hear me okay? Thank you, Amita. I began working in the field of mental health in 2001, and before that I'd worked with adults with learning disabilities in residential care. And I found mental health advocacy endlessly fascinating because of the various ways in which people exerted soft power to get people to take the meds. Always to take the meds. That was always the choice. The choice was to take the meds. There wasn't another choice on the table. The choice was to take the meds. Or, in eating disorders, to eat something. And so I eventually completed my law degree and did a PhD, which was about why people don't listen to what patients themselves said they wanted to do, and then became a lecturer at the University of Nottingham. And then I became quite ill myself, and I got the meds. I have epilepsy. These are my meds. So every morning I take 2 of the red ones, 1 of the white ones, 2 of the peach ones, and I do the same thing again in the evening. And that's good because that's why I'm able to stand here today. And probably a lot of people in this room also take meds of some description for various reasons. Because our bodies experience pain, our minds experience sadness, we feel fear. Matilda yesterday referred to taking hormones because she's a trans woman. We take the meds. And meds are quite good. Okay? If you have epilepsy, meds are quite handy. So I don't take the meds because I am forced to take the meds. But for me, going from not taking any medication to taking medication was quite a revelation. I used to joke to people that there's actually a school of sociology that uses a method called autoethnography that just writes up their experiences as autoethnography. Don't do an autoethnographic study of psychosocial disability. It's a stupid thing to do. If anyone here is thinking of going out, no. The first thing I discovered is that nobody forced me to take the meds. At no point was I legally required to take the meds. But I sat in lots of rooms with lots of doctors and discovered that it was very, very difficult for me not to take the meds. I felt very intimidated by the doctors. I found it very, very hard to ask questions, and I would have found it very hard to refuse to take the meds. And I have a PhD in medical law. And I had my husband with me. So if I found it difficult, that would help to explain why all the people I had worked with in psychiatric hospitals over the years also found it extremely difficult to challenge doctors' advice. And that continued for a long time. It continued for probably the first couple of years after I was diagnosed, until I was given a drug called lamotrigine. Lamotrigine is a very good drug for epilepsy, for a lot of people. For about 10% of people, it causes them to have a rash. And that rash can be very dangerous. If you don't stop taking the drug, it can cause an adverse reaction called Stevens-Johnson syndrome, which can be fatal. And I'm one of those 10% of people. The doctor didn't believe me when I said I had the rash. I got very ill, ended up in hospital. After that, I got a lot stroppier with the doctors. When the doctors said, you really need to take this, I just went, well, I'd like a bit more information first. This peach drug, for example, you really need to know when you take this, one of its side effects is psychosis. I'd have liked to have been told that before I took it. Only briefly. When you start taking it, you get over it. So it was a journey. There wasn't an event where I suddenly felt, now I'm an empowered patient, this is a free choice, I feel comfortable taking the meds. It was a journey. There also wasn't a point where I felt forced, but there were a lot of points where I felt I wasn't making a completely free choice. When we talk about alternatives to force, we need to remember that even when we remove legal force from the equation, what we really are trying to achieve is meaningful choice and meaningful refusal. As a patient, I now feel I am at that point. I make meaningful choices about my treatment because I am fairly well informed now about anti-epilepsy drugs. And I can refuse medication. And I don't know if other people here who take medication have had that experience. Once you have one diagnosis, you often find doctors push a lot of medication at you. So something that happens to me a lot is that I'll go to see the GP about something unrelated, and they say, oh, you look really tired. Sleep deprivation can trigger epileptic seizures. Do you need some Zopiclone so you can get a decent night's sleep? And I think, well, no, I'm really tired because I've got 2 young children. I might need contraception, but but no, I don't think I need more psychoactive drugs. So I refuse medication quite a bit, and I feel comfortable doing that. But again, it took me a long time to get to this point. Patient education is a huge part of becoming an informed, of becoming a person who is able to make a meaningful consent and meaningful refusal. But yesterday, after I gave my presentation, I had another transformative moment. I had a really powerful conversation with Rabina Alambaya, who's here from Uganda. She's the chair of the Pan-African Network of People with Psychosocial Disabilities. And Rabina came up to me and said, I was interested, you say you had epilepsy, because my mother had epilepsy. And Rabina's mother, like me, raised children. But Rabina's mother raised children with epilepsy in Uganda. Rabina's mother raised 8 children. I have 2 children, so she beats me at it. And I think raising children in Uganda sounds like a lot more work than raising children in Derbyshire in the United Kingdom, where I live. She had to grow their food, fetch water, fetch the firewood to provide for her children. So she had an enormous workload. And Rabina recalled feeling very frightened when her mother had seizures because she was scared that her mother was going to die. So the context in which Rabina's mother experienced her epilepsy and her treatment was entirely different to the one in which I experienced in my epilepsy and my treatment. And somebody this morning mentioned capitalism. Damn right. It costs £200 a month to prescribe that drug. That's not a choice that is available to huge sections of the world's population. It's a choice that's available to me, because I'm a rich woman living in a rich country with socialised medicine. So I don't actually have to pay that £200 a month. The taxpayer does. Whoever he is, but, you know, nice guy, I like him. When we talk about alternatives to forced treatment, we need to be thinking all the time about getting patients to the point where they have a choice. That choice is a meaningful choice. They know that their consent counts and that their refusal counts, and that they have the information that means that they can make both of those calls. Now, I know that Jolijn and Liz are going to go on and talk about what we can do to help patients get to that point. But those three critical conditions are rarely met in my country. So there is a huge amount of work we need to do before we can begin to think about how we can achieve this globally. And I'm sorry, I don't know how we're going to do it. I'm excited that we're having this conversation, and I would really value, I'm going to stop a little bit early so we have much more time for discussion. I would value everybody's input on this conversation. Thank you.
Thank you so much, Nell. I think the critical sentence for me there is that, yeah, I'm taking those meds, but I'm taking them voluntarily, and I'm taking them from an informed place now. So we'll have Jolijn continue this conversation. Again, Jolijn comes with a lot of personal experience, and the alternatives that she's going to talk to us today, family group conferencing, inspired from family group conferencing, is something that she has devised and tested, and she has a lot to tell us on that count. Jolijn.
Oh, it looks like my file disappeared. So I'm going to grab my USB. Sorry. That also disappeared.
You have it in your heart.
Yes, I think so.
Good for dependent on technology.
Yeah, it's my computer is fucked.
Yeah.
Okay. Okay, I'll try. I'm going to talk about alternative model that I have developed in the context of the law reform in the Netherlands. I come from Eindhoven. I marked it on the map, and the model is called Eindhoven model. Yeah, let's see if this works. There are a lot of alternatives to coercion that have been developed all over the world, such as open dialogue, soteria houses, wellness recovery action plans, healing homes, peer support. There's many alternatives out there. We will make sure there will be some information on that uploaded on the OneDrive. And I'm going to speak about this model of family group conferencing. I was invited in the law reform in the Netherlands, and it was going the wrong way, so I decided to make an alternative model myself, because I didn't think the government would come up with great ideas. And the current mental health laws, they focus on when to apply force. And I don't think that's the right question. The real question is, how can you support a person in a mental health crisis in a good way? how can you help people? I made a list of like what should this model all include, and I came to this model of family group conferencing. Originally, family group conferencing is an existing model which comes from New Zealand. It was developed in the 90s when the Maori population in New Zealand, they were disowned from their children and their land by the government. And of course, that caused huge resistance from the Maori population. So there were a lot of problems in the society. And at some point, the government realized that they could not go on taking away the children from the Maori population. And then they came to the idea, they took the children away because they had disagreements about how the traditional way of the upbringing of the children was done. For example, the government had laws, and they thought that every child should learn to read and write, and there should be no violence be used in upbringing, etc., etc. At some point, they asked the Maori population, how would you do it? And then what they did, they gathered around a tree all together, and they talked about it. Okay, how can we fulfill the request that the government has? And then they found, like, okay, we agree that our children can learn to read and write, but then they shouldn't learn it from the white people, but from ourselves. So they made their own plan, saying, okay, we can do this, but then in this way. And the government thought, okay, we can agree to that. So basically what they did is they made their own plan after the government had set out, like, these are the expectations. And this is basically the model of family group conferencing. And this has then been put in the law, the Children, Youth and Family Act from New Zealand from 1989. It says, families have the right to make their own plan first, and they should be supported to do so. So basically, this has been now a model used in childcare services mainly. It has been spread all over the world. Water. There are many places where they practice this model. Mainly in childcare services, but for example, in Scotland, they also use this for dementia in the community-based support. And maybe this sounds all a bit like family group is not like the biological family only. It relates more to extended family. So it can be also your friends, and it's based on choice. So basically you identify your own circle that you want to consult on a key question in life. And this is like the institutional, like the professionalized way of reflecting the model. The referral is not meant as a professional referral, but people don't naturally know that these models exist, so somebody has to point them at it. Then the second step, preparation, it means when you make the circle of people, there will be a facilitator, and he will make sure that the situation is safe. So, for example, when there's a family member that is rather dominant, they will say, like, okay, how can we balance this? In practice, you see that when there's, for example, a dominant father, when you then invite the parents, the grandparents, so to say, that gives more balance. So there are practical ways to bring balance in the circle. It's a little bit related to circles of support. That is also a model that has been used a lot. But circles of support is more like a long-term way of providing support, while family group conferencing really focuses on a key question about, it can be anything. It can be about how can I live in the community in a safe way. generally the question is phrased in a way that everybody can agree. So if I say, I don't want to be institutionalized, then people will have, you need to. But if the question is, how can I live in a community safe and independent, people can think like, okay, this is a good goal if it's safe. So then the conference itself, it starts with information. First you put everything on the table, everybody can give their views. You can have overview of all the services that are available or like anything. And then all the outsiders leave and the family stays, or the family group, they stay in their circle alone because then they can talk in their own language and their own values. And because the people know each other, they can speak more freely. Because the people who know you better, they also know when you are upset, or like it's less scary to be yourself when you are with your own people. And the choice is always with the main person. We call it main person, not a user or client. And then you make the plan, and the facilitator, who is like not a healthcare worker, but a neutral person who has just had a training of a couple of days on how to form the circle and how to arrange this. The facilitator will just only check the plan to see if it's like concrete, if it has like time limits, if there's somebody monitoring that the steps are actually being taken. And the focus is on how to find desirable solutions. And because psychosocial problems are very closely related to personal circumstances, you have to take the personal circumstances as the topic of the focus. So that's why family group conferencing is really focusing on the person in her life. So then it can combine the informal support and the formal support. For example, when somebody is scared to go out, persons may say like, oh, I can help you go to the shop. I can go with you. And these are actions that are typically not taken by professional healthcare workers. They have no time to go shopping with you. But friends and relatives, they often have not so much problem in doing these little things that can be really helpful. And this means that it's also less demanding from the professional services. Also, persons themselves, they know very well what would help them. For example, they need a job or they need to get out of poverty to feel better. So then they make a plan of how to do that. In the Netherlands, I started a pilot project with this model. There was university research attached. First, we started in Eindhoven, where I live, but it was really hard to find people willing to do this, because in a crisis situation, the professionals still prefer to use their own safe ways, but it's totally unsafe because they use coercion. So at some point we thought, okay, to break all this resistance, maybe we should scale it up and make it more a national project. So that's what we did. And then unfortunately, the professionals, they took over. They first made the funding application, and they started to use other words. I lost basically the influence. I was not listened to, and eventually they added more medical views. They said, oh, maybe you have to drug people before you can talk to them, or maybe we should have family group conferencing without the main person present when he's really distressed. So I was very upset. Last year the final report came out, and I really cried. So now I have a new goal. I want to start the project again, but now with a good group of people who have better values, and I want to have this human rights-based family group conferencing project. So if anybody is interested, contact me. Thank you.
So Jolijn has kind of given us two very solid ideas. One is that when you have experienced force, you know what all is wrong with it. More importantly, that it's possible to use everything the right and wrong way. We've had a lot of, we constantly encounter literature on what is sometimes a problem with the family. She's also telling us exactly how much of a resource is the family, how much of support is required in the family, but the need for having a range of strategies so that the power asymmetries can be addressed and everybody, the person for whom the family is conferencing, remains at the center. I think that's critical in what Jolijn has said. We'll take this further with Liz, and Liz kind of like comes in again from a very solid experiential come theoretical basis. She'd sort of tell us exactly what are the range of alternatives that have been devised and what works and how.
No pressure, Amita, the range of... Well, what I want to do in 15 minutes is look at two main ideas. Because we have, in a way, sort of examples from strategies for change, political change around the world, is that you work at the local level with groups of people and the interpersonal, but then you also try and look at the high level. The personal is politic. The old ideas from social change, from feminism, and I do think what we are. So I'll come to the high level strategic overarching question, which it taps into the themes I'm hearing from some of the feedback and from two examples we heard earlier. So I'm going to just talk briefly and introduce you to two approaches for working with people in crisis that are based on non-coercive, the respect and value for human approaches. Some of you may already be familiar with intentional peer support, which has been developed by Sherry Mead and Chris Hansen, they have taken this idea, coming from really experience of oppressive, violent, forceful treatment in different contexts, because there are women who didn't conform to the expectations of women in their cultures, and they're just not feisty women who often are the ones who are forcefully treated to bring into line through the social control type of process within structural process that psychiatry can fill. So, intentional peer support is informed by trauma. It's trauma-informed peer support. It has three principles and four tasks in developing a relationship with two people as peers and as equals, not that one person is employed to be a peer, and with all of the risk of the corruption of that relationship that can happen when peers go into mental health services, because inevitably they fall into the culture and the system and the way of working. This is a completely different model. So it goes from the helping model of the expert to people learning together. The individual, it takes the focus off the individual as having the problem to working and developing the relationship together between people so that they're equal, and you're working and you're taking the person out of the isolated, that the person is the problem. In fact, the idea is you work together to relationship, to see people as socially, connected. We all need to be part of communities, and it moves from the idea of fear to holding the idea of hope and possibility for change in people's lives. So the tasks that I haven't time to go into, but this is really well documented. It's all available, and it's really there for people to research more into it. I had the privilege of being trained by Shari and Chris quite a few years ago in the first peer support project that was set up in Ireland. And this was an independent one. It was kind of supported by a pretty good social worker who was trying to do things outside the system. So she managed to find ways through an organisation called Mental Health Ireland, who have little pockets of really good practice inside another big organisation that's a charity. But to be fair play to them, they're supporting some of these small little projects that can make a difference. And another Irish example, so that one is in, they set up a house called Auras Full On, which is in Tipperary, working on these principles because we were trained by Sherry and Chris. So the connection, these are the tasks in the relationship. You build connection, you share a worldview. You don't impose any model. You find what it is that the person believes is happening in their world and work with that. And you work together as pair, as an equal. There's no hierarchy. You find your level as human beings and you work on that. And then you always work towards trying to find solutions to what the problem is for the person. So another project that has started in Dublin, which is called Gateway, and that was even more independently run and developed by peers. So we have, and that's called Gateway, and both of those were actually sort of evaluated by a team of researchers at Trinity College who used participatory methods, and they trained service user researchers to do the research and evaluation with these two projects, the leaders, the people who went to them, and they actually wrote a report and launched it last year about the value and the way that these peer support projects work when they work on this basis of being equals together. Nobody is the expert. And so I invite anyone who wants to look that up to read it, because you can find it on mentalhealthireland.ie. Their website, they have this report of the evidence. This is something we're always searching for to combat the medical model, that evidence that this approach works for people who are given the freedom to do it properly without the professional takeover that Jolijn talked about. Another model I'm going to talk briefly about is the Soteria model houses. That is the idea that an actual place is, a physical house is in the community, is available for people to go to in crisis. It's non-medical in that it's not run by doctors. There may be people who have training in, psychiatric support medicine approaches, but it's not, like there might be nurses working in it, but it is not, it's always run on a non-medical basis. And the sense is, if a person who's going into it needs medication, has their own medication, they can bring it, but they are never ever forced to take it. So people can or not, medication is an available option if people have it prescribed and they bring it with them. So there's absolutely no forced treatment. The idea is a walk together with the person on the journey. But unfortunately, the experience, since this model was tried initiated by one of the hero psychiatrists we kind of talk about, because they're sometimes good people try to make change. Since that was started by Lauren Mosher, they've often been closed down, and quite often it's because the local traditional service feels, they don't like this model, and they use the paralegal, whatever, funding to close them down. So you can, there are chapters about this model in many books. You can find it online, and the reference I'm going to give you to look it up is on a website called Mad in America, because that's a collection and an introduction to a whole lot of these ideas for alternatives to coercion. So that's moving from some of the local examples. There are many of them, and we won't have time for me to certainly tell you about the plethora of them that's around the world, because these are local, small, individual efforts to make a difference, to offer people support and alternatives to having to, in a crisis, have no option or no alternative but to need to use a mental health system if it's there. This is very much from a Western perspective, I'm aware of that. So in our experience here in the West, and especially in Ireland, we're fighting an oppressive practice, an oppressive whole, because I think psychiatry is an industry. There's jobs in it, there's people employed. It is a whole system and layers of power. Yesterday, Laura was talking about trying to explain some of the many, many different levels and layers of power, and it is really complex, but all of these power structures are upheld by really strong systems of power within themselves. Psychiatry is upheld, first of all, and I thank the person for mentioning capitalism this morning, because these are the things that are not often talked about. In the big structural, the bigger macro picture of what's going on and what is it that keeps force in place. And so you have the psychiatric industry held up by medicine, the power of medicine to control our lives, to give us the answers to, so on some hand, we see the benefit of medicine when it's, based in things that are happening in our bodies. And like Nell, I too am really grateful for a particular form of medication that keeps me alive. But that's different. I choose to take that. It's not something that's ever forced on me. And I find it helps me. Whereas, my experience with being forcefully injected feels like a repetition of the trauma that brought me into the system in the first place. So we also have the legal system pinning up and supporting the power of this industry, which is big, and we've heard about thanks Lena. So we've heard about the systems and structures and the whole power of the legal system. And I was quite struck by, when you hear a professor of law talking about the proliferation of work and jobs and in that industry, when we have the legal structures that implement, regulate the power and the force of psychiatry to pick us up and off the street or anywhere else from our homes, which was one of the reasons I thought it was maybe good that you heard some of for those of you who are academics or studying this, those of us who've lived through it know this intimately, what it's like to be taken out of your home, to be taken away from the street. Back in the 90s, there's a woman called Liv Lindo, who used to speak about this as being akin to the experience of being kidnapped. You're taken out of your usual environment, your home. People break down the doors, and that study that we listened to, Mary Key's talking about yesterday. People break down the doors. Strangers come in a black van and break down the door if you don't open it, and they have the right to do this in law. Pick people up and bring them away, and they don't even have any responsibility to feed the pets or the animals that might be in the house, and they have absolutely no requirement to actually close the door behind them. So people have gone back and found that their front door has been left open in all the time they've been locked up and this is all underpinned by medical. And in my experience of sitting on mental health tribunals for a while as a layperson, I became horrified at the practice of some legal people who were using this as a cash cow. And then we have Big Pharma, and we think there's an awful lot of corruption in the whole research field and how and the construction of evidence around the pharmaceutical industry in the psychotropic medication, where they're frantically trying to find a cure for something that they can't even locate in the body because there are no tests or anything to locate a disorder in the body. It may be different when somebody acquires a definite brain injury, true, and there's a part of the brain that's physically injured. But and some people now are beginning to argue that trauma and all of the experiences of adverse experiences that people can experience as children, war, poverty, all of these things, that they can leave an impression on the brain. But to think that can be fixed by something as blunt as a chemical drug is like, it doesn't make sense. So, sorry, thanks, Clina, I saw that. So, basically, I'm saying we have a big oppressive industry that is upheld by capitalism, by the law, by all these structures and systems of power. And it's a bit like, the point that was made too by our colleague up here through Spanish. I mean, English has become, when you think of the difficulty of trying to change the way the world relies and uses English, I think, in a way, psychiatry it's become the same. It's like, it's almost unquestionable that this is the language, this is the way things are done. So, is it possible to reform that with soft means? And I do think the value of local interactions by people doing things in small ways for themselves in among community, and sharing that practice with each other around the world is really, really important. And sometimes it's something that's never ever talked about, is the value of the principles and the way this is done, in that it's done coming, I think if we were to work with each other in a way of love, and you rarely hear love talked about, because in our rational Enlightenment society, love doesn't really figure. And I'm talking about love not in the way it's corrupted, but in the pure sense of a compassionate, equal, dignified relationship. And so if we bring this love into relationships with each other, perhaps we can change it on a small scale. But in terms of a bigger alternative to capture, I want to mention an initiative that's been started by Tina Minkowitz through her work at the Centre for Human Rights of Youth and Survivors of Psychiatry. In 2016, she collected online through social media a collection of 41 case studies, people telling their stories about civil society, to support the work of the CRPD committee, to show that civil society supports the CRPD. And lately she started an online network, and part of that network, some of them are looking at the legal side of it, but some of them are looking at collecting evidence of all of these useful alternatives that are happening around the world, so we can show them that there are different ways of doing things, and do it by showing them that it can be done differently. And then it's the start of something that is about trying to get civil society in some ways to show the committee that this legal reform is necessary. So I'm going to leave it at that. Thank you.
Thank you so much, Liz. 3 ideas for me here. One, that let's not think of force as just innocent or something which is coming from a set of people who don't know what else to do. That there is there's a vested interest in force. There's a lot of people who kind of require it to be there. And consequently, alternatives are faced with this sort of beleaguering or this sort of taking over, which we need to be watching for. The other big thing that she's spoken about is the power of love, the necessity of having equal, respectful relationships, and the fact that larger structures in society should not prevent that from happening. We come to our last speaker, who again has straddled both the area of theory and practice. And I think Bhargavi is best describing what she would be doing, what she has done, and where she's kind of the alternatives that she has to offer for us today. Thank you.
Good morning, everyone. I'm really sorry to turn up like a bad penny every day on your table. I promise.
Also come back.
I promise this will be the last time. I'd like to start by saying that from the Global South perspective, medical legal coercion is probably less than customary normative cultural coercion as found in families and within communities. That's easy in some ways and difficult in many other ways, because you really need, I like what Liz said about having local actions. And so I think we will be presenting more from that point of view, that we are dealing here with more of cultural customary coercion, and we are looking at local action. Again, I have a few slides only as an aid to what I will be elaborating. I start with some of the visions that we had when we started the Bapu Trust work about 15 years ago. In Bapu Trust, we dream of healing environments where every person uses their own capacity to make choices, heal themselves, recover, and move on. We also envision that recovery methods will be creative, non-violent, non-hazardous, and playful. I've kind of peppered my presentation with all the stuff that we do in our program, which adds color, play, and fun into the support work that we do. Later on, as we started moving in the Basti communities of Pune, we found that this vision is still a bit individualistic. Over a period of time, we learned a lot from the altruism, solidarity, mutuality, connectivity that people enjoy in the slums of Pune. And we changed our vision in this way. So now our vision is to create emotionally sustainable and inclusive communities. Of course, we hope to also get into the CRPD with this new vision. I want to share some core principles of our programs. It helped us to build up our work and also connect with many of the programs that were discussed here. In this last year, I've been traveling a lot. Many of us from Asia have been traveling to different spaces where we are talking about alternatives to coercion. And also new ways of reclaiming communities and building new ways of life. And I want to start by making this difference between voluntarism and choice. Essentially, the CRPD makes us to think about choice as a way of creating opportunities for inclusion. And I want to say that voluntarism, which we talk about, informed consent, will and preferences, is still largely used within a medical legal context. And within the context of medical treatment, choice is much more. And inclusion needs choice, not just voluntarism. So I have got this table here. On one side, you have elements of voluntarism. On the other side, you have elements of choice. And I do believe choice is more CRPD compliant than voluntarism. There are many aspects to this, but in terms of time, I want to focus on two main differences. Within the frame of voluntarism, it means that users say, I will agree to take what you offer. I consent to what you offer. Whereas when it comes to choice, it means asking, what all do you have at your disposal as skill sets to offer me? Another difference is, when it comes to voluntarism, it also means, if I don't take what you offer, then I will have to face the consequences of my refusal. Whereas in terms of choice, it means that the user is suggesting to the support provider, if you don't have what I need, you just don't have enough. So you need some more skill sets with you. So voluntarism is about single transactions between the doctor and the user, and it is legally bound, usually by the mental health laws and associated laws. Whereas choice is about the availability of different supports and services in the community, and it is about the user's accessibility to those in nearby areas. So I really like the notion of using choice over voluntarism. Voluntarism, by the way, in the CRPD, it occurs in just one or two places, particularly in the healthcare article, but choice is in every article of the CRPD. So for me, inclusion and choice is the antidote or the cure for coercion. In our learnings here this morning and through the last years of exchange, with different user-led, survivor-led, disabled people-led programs coming from the West and our own experiences in the Global South, I have identified 4 key elements as really needed as antidotes to coercion and expanding choice. And I've got them here as 4 bullet points. Number 1, and I think this is really the priority, is being well and staying well strategies. In between crisis, what do you do to be well and stay well? The second one is peer support. Wherever we've gone, we've heard success stories from peer support systems. Also, of course, the failures when it gets co-opted into different levels of policy frames. But I'm really talking about grassroots peer support, where people are with each other without being bound by government funding or legal mechanisms and all of that. The third point is dialogue systems, whether they are with families, communities, neighborhoods, or service providers, having active and mindful, something which is thought about, having dialogue systems going, and crisis support. So I would identify these four as really key elements of alternatives to coercion, and we've heard it right through, whether it's soteria or whether it's the intentional peer support, family conferencing, all of that, family constellations, and different varieties thereof. There's the open dialogue, there's the trialogue methods. So we hear about many of these alternatives to coercion falling within one or the other of these four domains of support. In Asian cultures, we've found that peer support is not only by a fellow user, but by anybody who shares social, economic, cultural experiences of marginalization and exclusion. The peer support models that we hear about are still within the one-to-one kind of model. We've kind of expanded this to our own cultural experience of hanging out together in groups, not specifically on our own. And so for us, we have a rather fairly well-structured program of group support. Live storing. We do many activities in these groups, and it also, I think it phenomenally increases the potential for support within a community, because there are so many people with mutuality, mutual support giving and caring in that group. We work extensively building capacity for supporting and caregiving, particularly with families, but not just with families. We also work a lot with communities in the neighborhood. So if there is a person with psychosocial disability at a particular point, then we work around them. And we try to identify who is the person closest to them, who's the closest emotionally, who is the closest neighbor who is caring, so on and so forth, and then we build. And I don't believe that caregiving or support giving is a natural human thing. I think it has to be learned over a period of time. So we do a lot of stuff, for example, de-escalating aggression within households and communities, building nonviolent communications, building day-to-day, daily, simple peace practices, being attentive to and addressing basic needs, for example, food and fluid. When somebody is not eating, you notice that and start taking steps already in a supportive way, not in a controlling way. We invite in our work when we talk about dialogues, we don't have anything like trialogue or open dialogue, which is so structured, but we do have our own structures, open-ended structures for working, bringing different people into dialogue when somebody is facing a crisis. We did this training in Sri Lanka, and we asked one person to act as the person with the psychosocial disability. There were 120 people in training with us in that session. We made them stand in spiraling circles around this person, and we gave each one a blank white paper to fill. And they had to fill in a role, how they will support the person at the center. And our one rule was that you cannot repeat this, so you have to come up, each person had to come up with something new. And believe it or not, somebody was a milkman, somebody was throwing newspapers, somebody was managing the cattle, someone was a doctor, someone was a nurse, whatever. But each had something to say as what they could offer by way of support. In communities, you do find that many and more supporting things to do. So in Pune, we organize two different kinds of negotiation structures. One is what we call circle of care, which is benign, and people come around very willingly to kind of participate in caregiving for a person. We also, when we want to push a little bit, we have what we call confrontation meetings. When it's a bit more, we might call in the local religious head, or we might call the local policeman, or we might call the local women's organization person, so on and so forth. And we start pushing moral questions at the families. And usually, of course, we have some recalcitrant families, which, that takes another turn towards legal solutions. But usually people do turn towards what is the right thing to do. It's also really important to reach out and be with people when they come out of crisis. We say in our program that not every situation is a crisis, and we should keep ourselves de-escalated and cool to make more objective assessments. Self-care is a big part of our work in the communities, and also for all of us who are working as team in those communities. In crisis support, it's difficult to, this is a word salad that I made of the different things that we do. In crisis support, it's difficult to talk. Also, generally in Asia, people don't like to talk a lot. We're not very expressive linguistically, but we have various other forms of expression. So we have breathing practices, simple relaxation methods, a lot of community drumming, visualization, music, body and movement, song making, paints and colors, and so on. So many of us in the group, particularly the senior monitoring and mentoring group, we are trained as integrated arts-based therapists, and which again suits us culturally. When people go into Asia, they see noise. I hope you'll also see the color and the art. There's so much of that. Since we have a wide range of skills to offer, we wait to know from the person what they like and what they will like to pursue. May not always be in language, but we get to know, And sometimes, Kavita is here, she's leading the program, and we laugh about it because when they see the Bapu Trust team coming, some people run away. And they, okay, we're doing something wrong here. We should try other methods. And we're able to address diversity of needs because there is so much to offer. It's not just us, we ask anybody around us to help us with, and people do. And this is the last one, just so that you don't think that we've gone really crazy with all these different things going on. Our program is fairly structured, and we have what we call a modular arrangement of interventions. So, and it has, we call it the 8-point recovery framework, in which there is peer support, working with the person on strengths and resilience. We work a lot on well-being, self-care, all of that. Social capital is a concept that literally floods. It literally floods our program because we are constantly contacting partnerships, people in support, resource persons, people who will go on home visits, all of that. And so we do a lot of that through social friendships, encouraging people to go and join some sporting group or identity group or whatever. So we do a lot of work on social capital, self and self-care. Nutrition is again big. We do these inclusion, and I described 2 of those strategies. One is confrontation meetings, and the other is circle of care. And then we have like really big gestures of working with the community through awareness programs. It's been a pleasure being here. I thank you all for really patient listening, and look forward to meeting you all again. Thank you.
So what Bhargavi is kind of both stressed in principle and shown in practice, that you can't really speak about voluntarism without choice. You can't say that, you can choose for yourself, we want your consent, and then not really give any options. All the 4 presenters have in different ways brought home to you that there are enough and more alternatives to coercion, and it's possibly important for us to start engaging with those alternatives. With that, I sort of open up the discussion to the House. First set of questions, comments.